Okay. Well, thank you very much. And thank you for inviting me to speak about incorporating germline predisposition risk in treatment decisions of AML patients in 02. So AML is a heterogeneous disease that, even though it's rare in children, is associated with significant mortality. Many patients will enter remission after first-line treatment, but a third of them are likely to relapse. Hematopoietic stem cell transplant is the only curative option for these high-risk cases. Our recent findings are that about 19% of childhood AML patients harbor a pathogenic or likely pathogenic germline variant. And in the AML context, germline variants can influence the decision to transplant a patient, as well as the selection of a related donor if a germline pathogenic predisposition variant is identified. Certain variants might also alter treatment tolerance and therefore require considerations about conditioning regimens. Therefore, germline findings need to be made available to clinicians in time for transplant decisions, and this is challenging in a short time frame. So we decided to devise a framework and establish feasibility of fast-track reporting of clinically relevant germline variants in AML. To do this, we established a multidisciplinary team. This included clinical curators and bioinformaticians providing input into feasibility of the proposed pipelines, oncologists and transplant specialists providing relevance into treatment and transplant decisions, leukemia and familial cancer biologists providing their expertise on familial hematopoietic malignancy predisposition, as well as genetic counselors providing input into ethical considerations. We considered 95 genes that are clinically relevant to AML, and this included established familial hematopoietic malignancy-related genes such as RUNX1, GATA2, and CBP-alpha, as well as genes involved in bone marrow failure syndromes such as Fanconi anemia. We also considered other genes such as those involved in telomere biology disorders. Classification of variants also have the added complexity of gene-specific considerations such as biallelic events in FANC genes and somatic reversions in SAMD9 and SAMD9L. The consensus was also that in addition to pathogenic and likely pathogenic variants, we should also report on highly suspicious VUS. And this highlights the need for expert review in this classification process. So in conclusion, it was determined that fast-track reporting of 95 genes is not feasible in the 02 context, given the complexity of the considerations. But also, there's been changes recently to standard treatment protocols, which means that most patients will receive up to 3 rounds of chemotherapy prior to a transplant, by which time patients and donors can be worked up for tissue typing as well as germline considerations assessed. So we are hoping to provide a complete germline report at 8 weeks post-diagnosis, and this would include curation and classification of the 02 pan-cancer gene list, including highly suspicious VUS as determined by an expert panel. This will be presented to the MTB for recommendations with guidelines provided to clinicians in time for a transplant. Thank you.